Okay. So I think I have some slides. Do I have some slides? Okay, perfect. So you just heard conceptually where the country is going. I wanted to take us to Boston and Beth Israel Deaconess, where I oversee some 4 petabytes of data. I don't know if that's big data or not. I mean, 4 petabytes don't seem to have trouble backing it up, restoring it, and protecting it. And tell you what innovations have happened over the last 20 years, but where we're headed. It's to align to the precision medicine, cancer moonshot things you just heard about. So as Pete said, we've been on this trajectory for 30 years. Back in the days when the computer was as powerful as today's toaster, we went to electronic health records for our pharmacy, radiology, and ancillary systems. In fact, we built a very sophisticated security control system, role-based access control, with 26 different levels of role-based access control. Why 26? Those are the number of letters that could be stored in memory. 2K of RAM. What are you going to do with all that space? So over these 30 years, we've created such things as take paper records and digitize them. In effect, recapitulating the exact workflow processes we had on paper into digital form. Not very satisfying, I can tell you. And moving beyond that to such things as decision support, provider order entry, image management. Haven't used film since 1998. Haven't had a handwritten order since 2001. So it's been a trajectory. It's been progress. But as I say, not entirely satisfying. Yesterday, I actually saw an interesting big data analytic that looked at doctors' keystrokes over a 24-hour period. And it went something like this. The doctor logs on at 7 a.m., sees a patient every 12 minutes until 5. And we can actually look at keystrokes and see them change patient context. Then simply takes a break from 5 to 7 because you can't really see patients while driving home. But they would be connected if they could. At 7, after putting the kids to bed, they begin keystrokes again and continue until midnight. This is what we have done to the practice of medicine by inflicting not very usable and not very team-based systems on our doctors. All the regulations we've worked on for the last 8 years have been good, well-meaning, and in fact have taken us from a largely paper and manual-based process to a digital process, but there's a lot of work to do ahead. I even hate to show you this slide because yesterday I was on the phone with a startup in Palo Alto, so it must have been cool, where they said, we've created a social network-enabled, mobile-hosted, cloud-delivered machine learning analytics solution that's secure. It's like, what the hell are you talking about? But somebody will fund them, I'm sure. But it is true that we have not, as a profession, thought through some of these ideas so well. And I'll ask DJ a question he can't even answer. If you had to coordinate care across a big team of people for one of those patients you showed us, would it be easier in Epic or Facebook? You don't need to answer. The answer is Facebook. And that is because none of the electronic health record systems we've created to date were really designed for team-based care coordination across the community. So Beth Israel Deaconess, of course, as we look at the next few years, is how do we take the electronic health record from a dumb transactional system that gathers data for compliance and billing purposes and create a true team-based communication vehicle across doctors, nurses, physical therapists, social workers, patients, families, everyone in the community providing service. And I'll show you some examples of that. Today, and I actually looked at this analytic, we have 6,000 iPhones, 4,000 Android devices, 2,000 iPads, and 2 BlackBerries. They're both run, by the way, by chiefs of service. They have real keyboards. Cool. The mobile enablement of our workforce is our highest strategic priority. No one wants to use a desktop or a laptop. Clinicians are very mobile people going from the office to the nursing home to the hospital. In fact, if you look at today's access of all of our publicly available internet sites, over 80% are accessed from mobile devices. That's the trend. So today's electronic health records, not so mobile friendly in general. How do you think mobile native first, desktop or laptop second? So working on that. It is true that analytics, big data, all precision medicine is the future. And let me give you just a quick example. So my wife was diagnosed with stage 3A breast cancer in December of 2011, doing fine today. Korean female, 50 years old. The genomics on her cancer was estrogen positive, progesterone positive, HER2 negative. So of course the question we wanted to ask is, of the last 10,000 patients like her, how were they treated? What was the morbidity and mortality? What were the side effects? Are there things we should know about Asian females? So we did, because I am the CIO of all these hospitals, that big data analysis using some open source tools developed in part by Pete and his gang. And we were able to discern that for the last 10,000 patients seen in Boston like her, the combination of Taxol, adriamycin, and Cytoxan as chemotherapeutic agents would work pretty well, but you have to be really, really careful with the Taxol, because in Asian females, there's a tendency for Taxol to cause neuropathy, numbness of hands and feet. My wife's an artist. Numb hands and feet don't work so well for somebody who has to do finely detailed work. So we did a clinical trial of one. We decided that we would create half the dose of Taxol chemotherapy, but full doses of the others. And this is all informed by big data, the 10,000 patients who came before her, and she was cured. She has the full use of her hands and feet. It worked well. And that's the kind of analytics that we want every patient to have at every point of care. We have tried to move to the cloud for reasons of security, disaster recovery, robustness, and we have signed agreements with Google, Amazon, and other providers to do that. So I actually think in the next 5 years, CIOs like me will not provision IT, we will procure IT from cloud-based service providers. And that's going to make us much more agile and probably reduce cost. We must keep the trust of our patients along this path. I have had 2 federally reportable security breaches in the last 5 years. They're on the wall of shame. You can look them up. Neither of them were under my control. One, Dr. Famous, went down to the Apple store on Boylston, not his real name, by the way, and brought his laptop back to Beth Israel Deaconess, downloaded 119,000 email, went to a meeting, came back, laptop was gone. You know, not sure how I could have prevented that, and we now have spent over $1 million on forensics, government reporting, media management, legal fees, and fines. And fines were all appropriate, and a lot of control has been put in place. Similarly, we had a vendor come in and reconfigure one of our CT scanners and connect it to the public internet. Not a great idea. 2,000 images went off to China. Luckily, the Office of Civil Rights determined it was the vendor's fault, not ours. But I illustrate this because as we're on this journey of creating all these great new technologies, we must at the same time keep the data entirely safe. This gives you a sense of today how patients and doctors are using apps at Beth Israel Deaconess. Our EHR, which is self-built, it's probably the last self-built EHR in America, is mobile friendly. It uses a responsive design, runs just fine on your iPad. Our nurses are doing medication reconciliation and electronic medication administration using iPads and iPhones. Give you a list of the meds to deliver, who did you deliver them to, scan the patient, scan the med, scan the badge, make sure you're delivering right med, right time, right patient. Our patients, since 1999, have been able to access all their electronic health records, including notes written about them, on the web, and today it's now a responsive design. So that means nothing is done to you without you. And I can tell you, as a patient, as well as a doctor, it would be really hard to navigate the care of my family unless I had this kind of ubiquitous access to the data about all my family members. We've also created a variety of image management apps so that any one of our clinicians can see any film, CT, MRI, echo on their phone anywhere in the world. And recently we went live in all of our ICUs with a patient family dashboard. It's an app you can download on any device you bring. It's a BYOD kind of thing. So that if you have a loved one in the ICU, you can see their care plan, the progress on the care plan. You can see what's going to happen to them today and communicate with the care team all from your tablet device. My father died 3 years ago, my father-in-law a year ago. I managed their ICU stays. I can tell you, it's really hard to interpret the noise from all those devices generating all those data, the Internet of Things gone wild, unless you have this kind of dashboard that turns that data into wisdom and action. Our approach has been to create open source APIs. The idea that we actually want crowdsourcing. We want folks outside Beth Israel Deaconess to create apps. So when Apple creates CareKit, as you'll see in iOS 10, the idea that a patient can get their medical record on their phone, Send us survey data, send us Internet of Things data, look at a care plan, communicate with the doctors and care team members all from their phone is done through this API approach. So the future really is the IT guy, me, provides the basic infrastructure and the basic security and the policies, but we leverage the talent of those outside of our organization to create patient and doctor-facing apps. And one last comment on big data, which, again, don't know what it is. But I have today responsibility for 3,000 doctors and 450 locations of care running 26 different EHRs. I don't own them. They're just loose affiliates, friends, and family. And so we've had the job of taking the data from 26 EHRs, normalizing it into singular databases, and then providing data visualizations, behavioral change, process control, workflow analysis, that sort of thing. Very hard job, because Epic and Cerner and Meditech, eClinicalWorks, Athena, they all record data slightly differently. But so far, so good. We have made progress. We have been able to deliver to the government all the quality reports that are being asked of us. And we look to the future when in 2018, we're paid for quality and outcomes rather than quantity and the volume of care. And this kind of approach of normalizing data throughout the community and then giving ourselves some data visualizations is likely to work. Last thing I'll say is that the pillars that drive the IT organization at Beth Israel Deaconess today are ensure that we are capturing clinical documentation, and that's structured and unstructured data, because text is important too, and have the tools to search and interpret text. That we move entirely to mobile-based approaches for all data inputs and viewing. That we provide a layer beyond the EHR of care management. What disease do you have? What pathway do we enroll you in? How do you vary from that pathway? How do we keep you on a path to the goodness of the outcome we want to achieve? How do we do this from a cloud delivery mechanism, largely actually public cloud, Amazon, Google, and the like? And then how do we keep it away from, say, Yahoo email accounts as an exemplar? And that's a hard job. So thanks very much. And I do blog, as you say, and I'm available by email. I get 1,500 email a day, but I answer every one. Thanks.